Hi, in this video I am going to complete the 5-step practical approach by talking about the step number 5, studying both eyes. Now, studying both eyes is mandatory because we cannot take a proper decision when we study only one eye, for the following reasons. For inter-eye asymmetry scoring, to exclude form frost keratoconus and keratoconus suspect, to check misalignment and large angle kappa, to accept the skewed radial axis, and to check other corneal pathologies. Now, for inter-eye asymmetry scoring, as you know, this is an important step in the scoring of findings in corneal tomography, and we give the patient the score based on the asymmetry in terms of 5 parameters. And then if the patient has score 4, then it can be considered as moderate risk factor, and if the score is 5, then it is a high risk factor. To exclude form frost keratoconus and keratoconus suspect. Now, let us define these two terms. In order to define these two terms properly, we have to know the nomenclature of ectatic corneal diseases. Now, ectatic corneal diseases can be categorized into 3 categories. Category number 1 is established ectasia or ectatic corneal diseases per se, which includes keratoconus, pellucid marginal degeneration, pellucid-like keratoconus, keratoglobus, and post-laser vision correction ectasia. Keratoconus can be topographically defined as an abnormal anterior curvature map and an abnormal posterior elevation map, regardless of the thickness map, because it is very frequent that we can see normal thin corneas. So thickness is not an indicator of keratoconus. In pellucid marginal degeneration, we find, in addition to the abnormality on the anterior curvature map and posterior elevation map, the anterior elevation map takes the shape of crab claw, in addition to inferior thinning in the cornea, which very frequently takes the shape of a bell. So it is the bell shape corresponding to the inferior thinning of the cornea. In pellucid-like keratoconus, there is an abnormal anterior curvature map and an abnormal posterior elevation map, but the anterior curvature map shows a specific abnormality that is seen with pellucid marginal degeneration. This abnormality is crab claw, but there is no inferior thinning of the cornea. In keratoglobus, we find generalized steepening on the anterior curvature map and generalized thinning in the corneal thickness map extending to the limbus. This is a case of keratoglobus. In post-laser vision correction ectasia, we may find any abnormality of the previous ectatic corneal diseases. However, it is frequently taking the shape of keratoconus. Category number 2 is paraectasia, which is keratoconus suspect and form frost keratoconus. Now, in both these two terms, we find an abnormal anterior curvature map, but the posterior elevation map is normal. If we look at this elevation map, we find that the value corresponding to the thinnest location is +12, which is normal, and we find the anterior curvature map has an abnormality. Now, what is the difference between these two terms, the form frost keratoconus and keratoconus suspect? Whenever we find an abnormality in one eye and the other eye having keratoconus, we call this form frost keratoconus. So, in form frost keratoconus, the other eye has keratoconus. In keratoconus suspect, the other eye is either normal or has an abnormality, but which is not an ectatic corneal disease. So, keratoconus suspect might be in both eyes. Now, this is an example of form frost keratoconus. This patient has form frost keratoconus in the right eye, while he has keratoconus, frank keratoconus in the left eye. This is a case of keratoconus suspect. The anterior curvature map shows an abnormality in both eyes, while the posterior elevation maps do not show any abnormality. So in both eyes, there is keratoconus suspect. To check misalignment and large angle kappa. How do we check misalignment and large angle kappa, and how do we differentiate between both? We look at the pupil center coordinates and we compare both eyes. We look at X and Y in both eyes, and then we compare X with X and Y with Y. This is a case of misalignment. Whenever you find asymmetric coordinates, then there is a suspect of misalignment. Look at the difference between the two Y's. Now, usually, whenever there is more than 0.1 difference between both eyes, then we can say that misalignment is highly suspected. This is a case of misalignment. The patient was looking downward during taking the capture. Look at the amount of asymmetry between both eyes in terms of the Y coordinate of the pupil center. In the right eye, it is minus 0.66, while in the left eye is plus 0.1. This is a case of large angle kappa. This is the right eye and this is the left eye. And look at the symmetry in X coordinates. To accept the skewed radial axis. As I mentioned before, there are 4 reasons to accept or investigate skewed radial axis. They are less than 1 diopter of topographical astigmatism, large angle kappa, enantiomorphism, and misalignment. Of course, we cannot accept skewed radial axis in case of misalignment, but we can accept the skewed radial axis in case of topographical astigmatism, less than 1 diopter, large angle kappa, and enantiomorphism. So in these 3 conditions, we can accept skewed radial axis. Now, what is the enantiomorphism? It is a phenomenon where the left eye shows a mirror shape of the right eye in terms of topography, of course. Look at the curvature map and look at the thickness map. On the thickness map, there is a horizontal displacement towards temporal in both eyes. Finally, to check other corneal pathologies, because logically, when we find any abnormality in corneal tomography in one eye, then we have to take the patient to the slit lamp again to check for any abnormality that we missed in our primary examination. In the next video, I'm going to continue with other options, including small incision lenticule extraction or SMILE technique, phakic IOL implantation, and clear lens extraction. Thank you very much.